Hey, good evening, everybody. Welcome to our webinar tonight. We're going to talk about how to jumpstart your Step 1 study period, talk a little bit about some of the resources that are available, how to structure your calendar, questions, cover the whole gamut of things. Thank you so much for joining us tonight. My name is Mike Stevens. I am a PGY2 dermatology resident, as well as an MST tutor. I've been with MST for close to more than 2.5 years now, and thrilled to be able to work for such an incredible organization. And tonight I'm thrilled to be joined by Alec. Alec, do you want to introduce yourself?
Sure. Yeah, my name is Alec Grauman. I am MD PhD student at the University of Massachusetts. I have also been working with MST for a few years now, I think going on 4.5 years or so. And I'm really excited to be here with Mike to talk to you a little bit about how to jumpstart step one.
Awesome. All right. Well, let's just very briefly, just to give you a quick snapshot of who we are. We'll give you a little bit more information towards the end of the webinar, but basically an organization that's dedicated to student success through tutoring. And with that, I think we can kind of move into a little bit of a brief outline of what we're going to run through tonight. Start off by discussing how to think about your initial assessment scores, that kind of baseline NBME, and incorporation of that into your study plan going forward. Going to discuss I think the crux of what we'll talk about tonight is going to focus on the resources that you should be using in your dedicated study period, and with a special emphasis on triaging what's important, because it is relatively easy in the whole panoply of things that are available to you to review to get a little bit lost in all of that. And our goal is to help you kind of get through the weeds. How to incorporate all of that into a study schedule. And then I think you'll hear as we go through the evening kind of our thoughts on UWorld, and in particular the best ways that you should be incorporating it into how you approach this exam. Talk about some common mistakes to avoid, and then one of the best parts for me is we'll go through a couple of questions with y'all to kind of give you our thoughts on how to break down questions, and then do a few examples where we apply those principles. And then we'll wrap up with a live Q&A session. And so with that, I will turn it over to Alec, and we can kind of get started on thinking about, so Alec, what's your kind of thought process on how to interpret the initial NBME?
Yeah, it's just a really good question. And I think it's something that as tutors, we like to address with our students really early on, because NBME exams are really the best metric that we have for measuring step one success. So most students will start thinking about taking an NBME around the time that they start their dedicated study period. Some schools generally will have an NBME or a comprehensive basic science exam that they offer to their students. So you may, as a student, have already taken this or have it on your schedule upcoming this semester. So this first practice test, this practice step one exam, really is just used as an initial measure to see, where you're at this time. So one thing that I always like to tell my students is that when you take this first test, chances are you're not going to do so great compared to where you want to be. And that's totally okay, right? When you start off, this first exam is where you're at now. And what we like to do is use that as a way to plan what you need to do in order to reach that goal score. So because you probably haven't been following any sort of step one study schedule at this point, there's no expectation that you're going to knock this first exam out of the park. So we usually take this first exam and then evaluate it and use the score report to assess where your strengths are, where your weaknesses are, and really use that as a guideline to structure the study plan so that you can really, really focus on those weaknesses and make sure that you can bring them up to par with where you want to be for step one when you ultimately take the exam. So you really want to make sure that when you take this first NBME, you don't overemphasize the score and really focus on what content areas you want to work on. So from the point of taking the step one, this first practice exam, up through taking step one, you really need to focus on the quality of your studying and the amount of studying that you're going to be doing. And so we're going to move on and talk a little bit about how we can build that study plan and what resources we can use to help maximize your studying during this period.
Perfect. Perfect. And so with that, so after you've taken that NBME and now you're starting to dive into the content of what you'll be reviewing, kind of our approach and kind of the approach that I adopt when working with students is almost essentially tiering the options that you have available to you into different kind of strata, if you will. And what's really sits at the top and what you have to triage up front and make sure you're focusing on is are the two resources that you see on your screen. And Alec, I don't know what your kind of thoughts are or what you recommend to students, but to me, I am a big question guy. I love questions, huge proponent, and really to state it, I mean, I explicitly tell almost uniformly everybody, these have to be front and center in your study plan. Don't feel like you need to save them. Don't feel like you need to try to accrue a fund of knowledge and then dive into them. These are how you learn. They're not intended to be summative feedback in any way, like, you know, here's where you stand here. If you get all of these questions right, then you're going like, this is, you're not expected to get the questions right. You're expected to learn from the questions. And what you are expected to do is maintain a good pace through them so that you're learning the content you need to know in the time that you have. And so after, you know, having my piece about the importance of questions, I think that the benefit of the other resource you see here at step one, first aid for step one, is the fact that it does a good job of providing a decent scope of what that 90% of things that they could put on the test are. It's not comprehensive. Really, there's nothing out there that is. The sheer quantity of information that they can select from to put on this test is beyond what's reasonable to cram into a textbook. But this gives you that high yield kind of play-by-play of everything that, you know, the common things they like to pick from. Hard to learn from. You know, you're not going to necessarily become an expert in the physiology or pathophysiology of cardiovascular entities, but it'll help you fill in a lot of the blanks of, you know, the side effect of that medication or the clinical presentation of that disease. And so these two things really occupy, when I'm creating a calendar for a student, these two are kind of front and center. Alec, any other thoughts or things that you either put into the first tier of like primary resources, or any other thoughts about these two resources specifically?
Yeah, and I agree with everything that you're saying, Mike. I put first aid and UWorld kind of in that top tier of resources that I recommend to all my students. And I too feel that, you know, practice questions and doing UWorld questions it should be the main focus of what students are doing throughout the entirety of their step one period. It's not something that you wait for. It's something that you start from day one.
Right.
And I like to explain it as, you know, you've gone through M1 and M2 and potentially even some of your third year before you take step one. So you have all this knowledge, but really about taking these exams, you really have to learn how to apply that knowledge to standardized questions. And some people are really good at that. Some people have to work really hard at it. And the best way to practice applying all of that knowledge you've acquired is to just practice with questions.
Love it. I couldn't say it better. All right. And so with that, then, Alec, what kind of secondary resources do you often recommend?
Yeah. So, and this brings us to kind of the second tier, right? So everybody, I recommend, you know, you kind of have to use those two primary resources, really, no matter who you are, with very few exceptions. Secondary resources is where I kind of let my students mix and match based on their learning styles, what they feel like works well for them. One thing that you have to keep in mind when you're picking kind of these secondary resources is you don't want to overload yourself. You really want to be selective with however many resources you're using. So I generally tell my students that you get one additional resource to first aid and UWorld per subject. So if you like pathoma for pathology, then you get pathoma for pathology, but you're not allowed to use rapid review or any other pathology resource. If you like sketchy micro for microbiology, then you get to use sketchy, but that's the only other resource you get to use for microbiology. And that helps keep you really focused on the material that you need to learn without bouncing around to other resources and losing track of where you are. So generally, I let students kind of pick whatever they like for secondary resources. I'm not particularly tied to any individual one because so many people have different learning methods. So yeah, Mike, I don't know if you have any particular thoughts about secondary resources.
I love the way you said that. I find that, you know, when I'm working with someone and constructing a plan, exactly like you said, people learn differently. Some people really love the visuals of certain options. Some people really like the way that certain textbooks are written. And after the first aid and after the UWorld, I think that you can be a little bit more flexible in how you carve things out into the plan. And so to that end, then there's a lot of flexibility there, and it's a little bit of a finesse that you kind of work out with each individual student. But the key point is you have to be deliberate, and you can't just feel like let's throw everything on there because it's just too overwhelming. And so then kind of putting all of this together into one kind of framework is, you know, again, we talked about these primary resources, the first aid, UWorld, and again, these need to be kind of front and center. And so again, the first aid is just beautiful because it gives you that nice scope of what you need to know. You don't, it helps, it reins you in if you feel like you're getting too stuck into the weeds about the nitty gritty of some kind of immunological phenomenon or pathophysiological mechanism, and helps you kind of bring back, this is the forest, and not get too lost for all of the individual trees. Again, the UWorld is key. And then after that, then you can kind of build it into these other supplemental resources, be that Anki, be that Sketchy, Boards and Beyond, Pathoma, BRS. It's a little bit of just trying to find what works for you. But again, this is second, third tier, and has to take a backseat to these. And so Alec will talk a little bit more then about what that actually looks like in a practical sense.
Exactly. So once you've kind of picked what resources you like, you know what works for you, then it's time to start thinking about, how are you going to form that into an appropriate schedule, and how are you going to work your way through all this material. So we always like to start at a very high level approach, which first just is asking yourself, how many times do you feel like you're going to be able to get through this material? So when we talk about passes through UWorld, passes through first aid, we're talking about essentially going from front to back as many times as you're planning to get through the entire text or the entire question set. So we generally, with my students, I like to recommend to do either 2 passes or 3 passes, or something kind of in the middle, like a 2.5 pass approach. And really the way that we structure each of those passes is shifting from starting off with a very structured review and increasing the number of UWorld questions as you go through multiple passes. So at the beginning, on the first pass, a lot of your time is going to be spent reviewing topics, going through these secondary resources, essentially reteaching yourself all of the stuff that you may have forgotten from M1 and M2. And as we mentioned, doing questions is really important. So you want to be doing some UWorld questions during that first pass. Once you get through all the material, you start a second pass. And during this pass is when you really start to ramp up the number of questions you're doing and start practicing applying all of that information. So doing more questions and really letting how you're performing on the questions guide your review. So if you're doing really well on cardio, maybe you can lay off on studying cardio and focus more on something else. Like for me, neuroanatomy. I spent a lot of time in my second pass studying neuroanatomy because that was my weakness. So as you move through that second pass, you're doing more and more questions. And then if you can afford to do additional review after that second pass in a 2.5 or third pass through the material, it should be pretty much exclusively questions. You should be doing as many questions as you can, really practicing applying the material, and only reviewing things that you are really struggling with in UWorld and applying to practice questions. So by the end, I have my students trying to do anywhere from 120 to 160 questions per day, and that's the majority of their time is spent doing questions. Mike, do you have any differences in how you structure your passes with students?
I agree wholeheartedly. I think that it's to some extent you have to prioritize quantity. And it is a little bit uncomfortable. I did not practice what I preach now when I was doing this, and I was slow and it took me a long time to get through questions. But the reality is that there's just so much out there that even if you don't feel like you're assimilating everything you want to from any individual question explanation, you're just learning so much from reading questions, from trying to figure out what the answer is. And it may not be tangible. You may not be able to put your finger on like, well, I have this whole UWorld table memorized, but if you just keep working through questions and have kind of a lean into the system a little bit, it works. It really works. And, when you're getting towards the end of your first pass and then starting these subsequent passes, the reality is that that information that had kind of been washing over you end up having a lot of you hold on to that. It's somewhere in your brain, you're remembering it, and pieces start to get connected, and before you know it, you kind of got all of this down. And so I agree 100%. Just as many questions as you can, as many as you can each day. I'm maybe a little bit more conservative on the range of like 80 to 120. I find that especially after 160, I think your yields start to diminish a little bit. But if students are into it, if they're moving quickly, I'm all about like 160 questions a day. That's phenomenal. All right. And so when you're kind of putting together your calendar of how you're going to approach all of this, the key thing is to have that conversation with yourself about what do you want to get through, what's realistic. And so that would essentially, you need to say, I'm going to let go of X, Y, and Z of our kind of tertiary resources, if you will, but focus in on, let's say, I really like the visuals of Sketchy Micro or Sketchy Farm. And so then once you know what resources you're going to be focusing on, kind of divvy that up over the course of the time period that you have and work through it. The way that I typically structure things with students is we'll create a Google Calendar together. We'll kind of adapt it in real time, but very clear objectives for each individual day. Because what can happen is it might feel like you have a long time. A dedicated study period might be 6 weeks, 8 weeks, 12 weeks, but you have to. It's easy to run out of time that way if you're not being very diligent on a day-by-day basis. So have clear goals for every individual day. Here's the number of questions. If I'm going to get this many questions done and I have this many days, then every day I need to do that number of questions divided by that number of days. And just do that. That's has to be your goal. And then, you also want to continue to have that conversation with yourself about, is what I'm doing realistic? Am I burning out quickly? Am I putting in 14-hour days every single day? Am I trying way too hard to incorporate way too many resources? And if you realize that that's what you're not on a sustainable path, then you may have to deviate course, and that's okay. But it's better to do that up front than to try to keep plugging along an unrealistic path and ending up spending like 2 weeks reviewing just cardio at the expense of everything else. Alec, anything else about how when you're working with students, develop a calendar, or any recommendations you give students?
Yeah, and I think, a lot of the things that you've mentioned, I also do with my students as well. So, working with the Google Calendar, I've worked with just an Excel spreadsheet with some students, and it really just depends on what, you're comfortable with, so the method that you kind of track your progress and that you build that calendar can vary, and it's really up to you. But I agree completely with Mike that you need to be flexible with your time, and with that calendar, it needs to be almost like a living being, and it can change with how your effective your studying is on a day-to-day basis. But having that plan and planning it out really gives you the opportunity to visualize what your day-to-day progress is going to look like, and assess, like, is that actually feasible for me as a studier? So I think on the next slide, we have an example of what a dedicated study period timeline might look like. And this is really not even remotely as detailed as what we normally work with students to build. If we were to try to put one of those on a slide, I think it probably would be like 4 or 5 or 6 slides to get through an entire dedicated study period. But here what we have is just a breakdown of the different systems that you might be studying on a different day. So, you can see here that, during this first pass, each organ system is allotted about 2 days worth of study time to get through the material and first aid and to get through any additional secondary resources that somebody might try to be working through, as well as doing questions related to that organ system. And then as you move from that first pass to the second pass, shown here on week 5, where cardio shows up again, that shrinks from 2 days to 1 day, right? You've already gone through the material, so you're relatively familiar with it. Now you're just hitting those high yield points, the things that you're a little bit weaker on in each organ system. And then by the time you get to this third pass in week 7, starting on Monday with cardio again, right? Some of these organ systems may not even be showing up again, right? Those are the organ systems that you feel most comfortable with, and you're like, I don't really need to study those in depth anymore. So I'm really going to focus down on the material that I'm not comfortable with. One other thing I always like to point out is on these calendars, we have interspersed NBMEs. So these are practice exams where you can take a test and essentially project how well you would do if you were to take step 1 on that day. And what this does is it allows you to track your progress. So you can take that test and you can say, oh, well, look, I studied neuro recently. I'm doing really well in neuro, so maybe I don't need to spend as much time studying neuro on my next pass. But I really struggled with cardio. So I want to make sure that on my next pass, I give cardio a little extra time. So tracking your progress and seeing your trajectory on your scores, as well as how well you're performing in each organ system, can really help you adapt how your calendar looks for the remainder of your study period. So this is actually pretty similar to what a lot of my calendars look like, just with a bunch of additional details. Mike, do you have any differences in this calendar and what you usually put together with your students?
No, I mean, I think this is a great example, and kind of all of the points that you mentioned, I agree wholeheartedly. I think also, and I know you highlighted this, just the timing of the NBMEs, be diligent about them, because they kind of, I think the ideal scenario that I try to incorporate is you have kind of time on the x-axis, you have NBME scores on the y-axis, and you want to see kind of like a nice upward trend over time. And that is a good indicator that the trajectory that you're on, the way that you're approaching things is a good one. And you have concrete data that supports that. And if you cluster all of your NBMEs at the end, well, then you're not exactly being very diligent about self-assessing in real time. And you have so many, that's the beautiful thing about step 1, is you just have so many good quality practice tests available to you in terms of the number of NBMEs, the UWorld self-assessments, and a lot of the other Qbanks that are up and coming that have developed good quality practice tests as well. And so, leverage that to your advantage and utilize it. I think it's a common pitfall that many people fall into. And then the one other thing I'll mention is just that timing of that last NBME. I really am a big advocate of not testing too close to test day. I find that if you're not, unless you are ready to unless you have already had the discussion with yourself, if this does not go well, I'm rescheduling my test, do not take an NBME the day before or 2 days before. Because if it goes poorly and you're already still going to be taking the test no matter what, you're just creating anxiety. You're going to be going into that exam with that hanging over your head of well, that practice test really did not go well. And so to that, and then unless you're ready to reschedule, it's honestly probably better not to do the NBME. That's one of the few scenarios where I advocate against practice tests. All right. And so again, I think just to reiterate that discussion we'd had before, be realistic. And it's okay if you feel like what you're doing is not sustainable. Again, it's better to deviate from the course that you're on if it's not possible early on than to just dig your heels in and try to keep chugging forward. And so, if you're feeling burned out, if you feel like you just don't have the energy to do another question, if you feel like, you're constantly scraping as many minutes out of your day as you can at the expense of sleeping, at the expense of taking care of life events that still happen regardless of whether you're in your study period or not, then you need to have that conversation with yourself. All right, Alec, how about any other tips that you recommend in terms of approaching this?
Yeah, absolutely. And I also wanted to emphasize, and I think, Mike has mentioned this as well, or you probably have picked up on it, that there's a lot of variability between study schedules and learning styles and everything between students. So just keep that in mind as you're developing your study schedule, as you're picking out resources. You're an individual, and so it would be really great if we could give you a perfect recipe for how to get a 260 on step one and it worked for everybody. But that's not the case, right? You have to kind of mix and match and figure out what works for you. So just keep that in mind as you're going through that. Just because something works for one person doesn't necessarily mean it's a good decision for you. That said, we have found that there are certain things that you can focus on and certain things that generally are true for a lot of students. So some of these tips are here. So one thing that I find really slows students down is agonizing over pages in first aid, whether it's being frustrated that they can't memorize every little bit, that after the first pass they flip back to a page and they don't remember little pieces of information. Don't worry about that. You're going to be seeing every page in first aid 4 or 5 times over the entirety of the study period, between reading the book, reviewing from UWorld questions, comparing between different resources. If you don't remember it the first time through, just relax. You're going to see that many, many times. It will stick eventually, and the repetition is more important than knowing it the first time for every single piece of information. Don't use too many resources, right? We talked a little bit about how that can be really overwhelming. Resources can really suck your time away. Watching too many videos can really suck your time away. So you want to make sure that you're diligent and very efficient with your resource use. So like I tell my students, you get first aid, you get UWorld, and then you get one additional resource per topic. So that could end up being a couple of different resources, but you're not going to be using an additional resource, 2 or 3 additional resources for, say, cardiology. Similar to first aid, you're not going to remember everything in UWorld right away, right? As Mike was saying earlier, it's a learning tool, right? You're using it to learn material. You're using it to learn how to apply all of that knowledge to a question so you can get that question right. And every question that you get right is a great thing. Every question you get wrong, honestly, is even better, because it helps you learn that piece of information that you missed, figure out exactly what you need to know to get that question right the next time. And it tends to stick better when you get something wrong. It'll stick in your brain a little bit better than if you get it right. We talk a lot about, how in depth do you need to study a particular subject. You want to make sure that you're studying everything at an appropriate depth. And what I also tell my students is, if you're really interested in something, step one dedicated study period is not necessarily the time that you want to really delve into all of the studies and management and nitty gritty details of that particular field, right? Save that for when you're a third year and you want to impress an attending. You want to make sure that you're focusing on your weaknesses. So even if you hate a particular subject, or it really is a struggle for you, like I always go back to neuroanatomy. I've spent more hours studying neuroanatomy than anything else for step one, because it was the thing that I was the weakest at. So making sure that you're appropriately studying every subject at the breadth and depth that's necessary is really important. We talked about scheduling and how your schedule should be very fluid. You want to make sure that there is structure, but you should be ready for that structure to change as you go through the study schedule. As I think this actually comes back to that first bullet point, don't overstudy a topic, move on, right? This is not the time to learn everything that you can about the heart, right? You want to learn what you need to know about the heart and then move on to the lungs. And again, that hits the last bullet point, right? High yield topics only, right? You can learn all of the information that you want at a later date. Now is the time to really focus on the most important things that are going to be showing up on the test. And as Mike mentioned earlier, first aid is a really great way to figure that out. If it's not in first aid, you probably shouldn't be spending a lot of time studying it. Mike, I don't know if you have any other sweet tips to help reach your best score.
Ali, that was amazing. I honestly, you brought up so many key points, and I agree really with everything you said. And if I could just recapitulate a couple of the things, is just, this is all of medical school, frankly. There's just so much information that a lot of this is just learning and forgetting. And so you're not going to be an expert in all of this the first time you see it in a UWorld question or the first time you flip through it in first aid. But, the more often you just repetition over and over and over again, as many times as you can, and it will sink in over time. Again, the other key point that I think you did phenomenal. I mean, the key thing is quantity. You just need to keep moving through material and just resist the temptation to feel like you need to become an expert in any individual thing. There's so many different things that they could ask you on that it's better to be a little bit good at 90% than to be really, really good at 10%. All right. And so just to hone in a little bit more on the UWorld specifically, I think this is a point that we brought up a couple of times now, but the UWorld is formative. It's not summative. It's not intended to say, here's where you are at this moment in time. Here's what your 3-digit score will be because you got this many questions right or wrong. It's purely intended to be, these are things you need to know, and we're just going to take that information and write it in a way where it's now in a question format. And so that's how you should view this. There are calculators online that will convert your percentage into a 3-digit. No, none of it. Avoid all of it. Avoid the Reddit feeds. Avoid all of it. They're not helpful. This is not the way you should be viewing the UWorld. Do as many passes as you can through the UWorld. If you're kind of at in a little bit of a time crunch, then you can focus in on just repeating your incorrect questions as opposed to doing all of them, because that'll triage the things that inherently you might need to focus on a little bit more. Use the questions the way they're intended. Don't feel like you need to take a bunch of explanations and staple them together. This is not a textbook. And just reading explanations passively is kind of antithetical to the entire way that UWorld is so effective at teaching. And so make sure you're not treating it like it's a step 1 textbook. One proponent, one way, I'm a kind of a proponent of if you want to find ways to be more efficient as you're working through the UWorld, is identify 1 or 2 facts that you didn't know before you did the question, and find some way to either anchor that in your head, put it in an Excel spreadsheet, in a OneNote file, in a Word document, in a Google Doc, or on an Anki flashcard or a Quizlet flashcard, or whatever you want that to be. But really restrict yourself to 1 item, because I was so guilty of this. I would inevitably end up writing out the entire explanation, and it took me like 20 minutes to get through a UWorld question, and that's just not sustainable. You really need to be looking at like 3, 4, 5 minutes per question. But whatever you want it to be, find some way to kind of take that information that you want from each individual question. If you're constantly learning things you didn't know before, the UWorld will always be there, and you can always come back to it. Your limiting factor is the time that you have in your dedicated study period. And if you're constantly devoting that to things that you don't know, that is high yield, then you are operating at 100% efficiency. No matter how you do things, no matter how you structure things, if you're constantly doing that, you're always operating at 100% efficiency. And our goal is just to help you structure your schedule in a way that optimizes your ability to do exactly that. So anyway, that's my, I'll step off of my soapbox about UWorld. Alec, anything else that you recommend to people?
Yeah, I want to repeat that point about 1 main takeaway per question from a UWorld question, because I think, and I too had this issue early on, especially because there's so much good information in those explanations that you're tempted to just write the whole thing out and spend a bunch of time reading it. So what I generally recommend to my students is you have to ask yourself the question, what piece of information did I need to know to get this question right, if you got it right? Or if I had known blank, I would have gotten this question right. And that piece of information is what should be going on a flashcard or going in your notebook, right? So distill it down to that thing that you particularly need. And hopefully that's a better way to work through UWorld questions a little bit more efficiently.
All right.
Excellent.
Now, yeah, take it away, Alec. How do you with these?
Yeah, so now we're to the fun part. This is the part that I think a lot of tutors really like. We for better or worse, really love doing questions, and you probably gathered that from this presentation so far. So, working through how to approach these USMLE style questions is something that it's a skill in and of itself, just like CPR or giving an IV. Like, it's something that you can practice. It's something that you can learn how to do, just like any other skill that you learn. So for me, there are a couple of things that I like to do looking at a USMLE question, and you'll probably find that the way that Mike and I do questions is a little bit different. So I'll give you a lowdown of how I approach questions, and then he'll give a couple examples as well. So for me, I always start with the last line of the STEM, which is the actual question, the lead-in, and that's what I always start with. So for this question, which of the following autopsy findings is most likely seen? So that's where I start with the question. What I do next is ignore the answer choices. Never look at the answer choices before I actually read the STEM, and try to come up with a differential on my own. So after reading the lead-in, I'll go back to the top and read the entire question myself. And as I'm reading, I usually go sentence by sentence, and I try to pick out key pieces of information. And that includes the demographics, because epidemiology is really important on the boards. Looking at what other kinds of clues they're giving in the history. Is there any sort of past medical history? Are they telling you anything about family history? And then once you get to the physical exam findings, you can kind of approach this similarly to as if you were seeing a patient in clinic. So by the end, once I've gone through all the information, I try to formulate a little bit of a differential diagnosis in my head. What do I think is going on with this patient? Can I come up with 2 or 3 possible diseases, and then apply that last line of the question, the actual question itself, to that differential before I look at the answer choices. So that's my approach to just dissecting the STEM. Once I kind of have all that sorted out, then I'll go to the answer choices and look for an answer that kind of fits with my differential. And one thing that we always have to work on with students, because this is not something that anybody is born with, is how do you approach answer choices in a way that allows you to connect what's happening in the STEM to how the answer choice is written. So a lot of what happens on the USMLE is they'll use synonyms, they'll use descriptors, they'll ask you to go one step further. So it won't be a question about the disease, it'll be a question about what's the mechanism, or what's the pathologic finding, or what is a related symptom from a different disease. So they'll always take it one step further. Well, not always, but a lot of the tougher questions, they're asking you to go to that second step. So making sure that you pay attention to synonyms, different terminology, and how you can kind of connect that back to disease processes is really important. So those are the kind of the ways that I approach it. I think it would be helpful if we just go through 1 or 2 questions, and Mike and I will give you a lowdown of exactly how we would approach some brand new questions that I think we have not seen until just like right before we started this presentation. So it'll be totally fresh.
All right, awesome. And if you guys feel like you know the direction that we're going with the question, or you want to chime in with the answer, feel free at any point to document that in the chat box. And so I agree. I mean, everything Alec mentioned on the previous slide, agree 100%. So I'm going to start with, just like he talked about, I'm going to start with the question itself. Cardiac auscultation is most likely to reveal which of the following. And I'm also just going to take a quick glance at the answer choices that are here. And a lot of these look like those murmur phrases, those kind of buzzwords to murmurs. And so we were dealing with some kind of presumably a cardiovascular question. And what we need to do then is we need to figure out what disease entity we're dealing with, and then map that back onto what it would sound like. And so with that kind of in our head, we now know what the important things that we need to take away from the question, from the STEM of the vignette, are going to be. So 37-year-old pregnant woman, 22 weeks gestation, comes to the physician complaining of cough and dyspnea on exertion for the past month. Okay, so she's pregnant, which is kind of important to know, a relevant aspect of her past medical history. She reports occasional palpitations and 1 instance of coughing up blood a few days ago. And so this is their way of communicating that she's having some hemoptysis. And there's a limited differential of things that might cause hemoptysis. Again, we're going to be thinking about this in the context of something that might cause something cardiovascular related. So there are pulmonary things that can cause hemoptysis. There are rheumatologic things that can drive that. And then what we're thinking about mainly based on our skim of the answers is something cardiovascular. She's noticed progressively worsening shortness of breath over the last month, is now unable to sleep flat. And so this is a good example of what Alec was referring to before, the synonyms. I call them hidden buzzwords. It's neologism that I've come up with about they don't necessarily give you the word. It's not, I think they're moving away from just pure word association, and they describe the finding, or they describe the symptom, or they describe the appearance of something, and make you kind of map it back onto that buzzword to make it a little less of a giveaway. So what they're referring to here with this inability to sleep flat is orthopnea. No fevers, chills, speed and production, runny nose or chest pain, no significant past medical history, pregnancy has been uncomplicated. Social history is unremarkable, moved to the US from Indonesia 15 years ago. So oftentimes what happens is when they give you these kind of ancillary details that they might not present in every single question, they're going one of two ways with it. They're either, more often than not, when they give you this information, they give it to you for a reason. Sometimes they get a little bit tricky and they lead you down red herrings with a family history to make you think about something else. But this is a little bit specific. When you're thinking about a patient who has immigrated to the US, then potentially some of the things that we might catch with our standardized vaccination schedules, newborn screening, treatment protocols for certain conditions might not be standardized across the world. And so that's something to keep in mind, that you need to have on your radar, things that might be a little bit rarer in the US, but might be more common elsewhere. The patient is alert and in no acute distress. She's afebrile. She's normotensive. She's a little bit tachycardic, and her heart rate is irregularly irregular. When you hear irregularly irregular, that in of itself should kind of trigger. If anyone, I'm actually going to leave that out there. I'm going to have people, if you know what that might be referring to, drop that in the chat and we'll talk about it. Oh, great. People are so on it. They're already chiming in. Respiratory rate is fine. And then lung exam has crackles at the base of the bilateral. Great. So AFib. So AFib, in the context of this as well, is also thrown in. So I think just to take out of this, the key things that we're dealing with is we have a patient who has hemoptysis, who is pregnant, who has moved to the US from Indonesia 15 years ago, and is now presenting with AFib that may or may not be chronic, as well as cough and dyspnea on exertion. And so diving into the answer choices then, as I march through these, also, if you guys are so on it, if you know what each of these answer choices is referring to, also feel free to drop that into the chat. But so A is a continuous harsh, great, people are already chiming in, a continuous harsh machine-like murmur best heard at the left infraclavicular space. Awesome. So when you're hearing that continuous murmur, and it's often described as machine-like, think about a patent ductus arteriosus. And so that would be a good thought in someone who maybe, if she had that at birth and it wasn't repaired up until now, then potentially that the overall vignette, though, it just doesn't fit with the things that you would expect with hemoptysis, with new atrial fibrillation, with overall the clinical presentation that she's having now is not quite as consistent. An extra heart sound in late diastole, best heard at the cardiac apex. I'll let you guys chime in if you think you know what that might be referring to. And while we're doing that, an early decrescendo diastolic murmur, best heard at the second intercostal space. Okay, so for B, I think we got S4, perfect. So that's an S4 when you're hearing late, an extra hard sound. So S1 and S2, then you have S3 and you have S4. And so perfect. That's exactly, think about pressure overload. Not consistent here either. That would be like longstanding chronic hypertension, which this patient does not have. And then that diastolic murmur, early decrescendo, think about aortic stenosis for that. That's the description for AS. A holosystolic murmur best heard over the left lower sternal border. And so what you're thinking about there is that location is kind of classic. So holosystolic, think either mitral regurgitation or ventricular septal defect. In this case, based on the location you're listening, I would probably think more ventricular septal defect. Again, similar to the PDA, it would cause more of a cyanotic disease once you have Eisenmenger syndrome, which this patient is kind of out of the window for that kind of condition. And then last, we have a late diastolic rumbling murmur, best heard over the cardiac apex. And so great. So people are chiming in that they feel like this might be the answer, and that's perfect. So this is mitral stenosis. Taking a step back before we dive into that, you basically go through each of these answer choices, take these phrases and put them onto real diagnoses, and then map that back onto the vignette that you're dealing with about what corresponds to the condition the patient has. So hemoptysis, atrial fibrillation, her blood can't get through the stenotic aortic mitral valve. And so the left atrium dilates. Any kind of atrial dilation is going to predispose to these aberrant arrhythmias, like atrial fibrillation. And then you're going to back up into the lungs, and it causes hemoptysis as well. Pregnancy does not respond well to stenotic heart valves. Regurgitant, because it's a state of volume expansion, you actually do a little bit better with regurgitation than you do with stenosis, but stenosis is very hard for the physiologic adaptations that happen with pregnancy. It's hard for that to work in the setting of having a stenotic valve. And so that's kind of the approach. That's the way to think about it. Kind of go through each of the answer choices and figure it out from there. Alec, any other tips or tricks that you would use for a question like this?
That was beautiful. It was like a work of art. I loved it. That was very exciting to listen to. There's nothing else that I picked up on the question that I think would be helpful. And I love the idea of translating answer choices to the disease process that they're referring to. I think that is it's a wonderful way to help kind of, work your way forward from the stem and then backward from the answer choices to meet in the middle. And I think that, that's a very, very useful trick. Love it.
Awesome. All right, let's do it again. Let's try a second question.
All right. I will go ahead and take this one. So similarly to how I started, I tend to not look at answer choices. Mike had a really great tip where you can glance at them if you want and kind of just gauge, sort of what the answer choices might be going for. I'm going to try to not look at these, which is a little bit hard. But I'll start with the last sentence. So which of the following likely led to the development of his representation? Okay. So this is a common thing that you'll see a lot in UWorld is, you don't get a lot from this question. I mean, we don't know anything about the disease process. We don't know anything about the organ system at this point. We really have no idea. We know that he's coming back to the hospital or to the office, and we're going to start thinking about why that might be. But this was a little bit less helpful than some of the other questions that we previously looked at. So we're kind of going into this still up at 30,000 feet. We don't really know what we're thinking about quite yet. So we'll jump back up to the top. Okay, so we have a 67-year-old man who's presenting to the emergency department with crushing chest pain. Oh, wow. That's pretty classic for a particular disease process. If anybody wants to pop that into the chat, I won't say anything. We'll come back to that. Oh, love it. So he reports he usually has mild pain after walking 3 blocks, but this has progressed to be present at rest. Okay, boom. So now we're having pain at rest, whereas before it seemed to be some chest pain on exertion. I'm going to try to go through this without saying any diseases, and y'all can jump in. Oh, great. This is lovely. Oh, you're doing so wonderful. He has also had worsening shortness of breath and sputum production over the past 2 years, along with, a 70-pack year smoking history. Wow. Okay, so we have this guy who's been smoking for a lifetime, and he's been having worsening shortness of breath over 2 years. So right now, what are we thinking? We're thinking he has this cardiac issue, and with shortness of breath and sputum production, the sputum production seems like maybe a pulmonary issue. So if we think a little bit back to the question itself, right, representation, okay, maybe he's representing for more of a cardiac issue. Maybe we're going a little bit more towards pulmonary. Excellent. So potentially COPD, potentially chronic bronchitis. Love it. Okay, so he's in the hospital and he's getting an EKG, which indicates a left circumflex ST elevation MI. Perfect. So whoever said MI at the beginning, you can give yourself a pat on the back. Love it. So he's having an ST elevation MI. So he has, he receives a stent and is discharged 2 days later on aspirin, clopidogrel, and propranolol. Okay. So one thing that I always like to do is check myself, and when I see drugs, make sure that I kind of know what class they're in at least, because that may be something that's important, right? Maybe we're going to get a drug-related question here. So aspirin, an antiplatelet, clopidogrel, also an antiplatelet, and propranolol, which is I'll leave it up to you guys. Okay, so the next day, he represents to the emergency department with 2 hours of shortness of breath. Okay, so we're back, shortness of breath for 2 hours. And on this representation, here are his vitals. So he has a temperature of 98.9, heart rate 92, respiratory rate is 22. That's a little bit elevated. And he has a blood pressure of 142 over 91. So elevated blood pressure. And his oxygen saturation is 90%. So that's pretty down. Not super dangerous yet, but 90% in a guy with potentially COPD and a very long smoking history, a concerning oxygen saturation. So he has a cardiovascular exam, normal S1 and S2, normal jugular venous pressure. So what does that tell us about what is not causing his current shortness of breath? So if you were perfect, oh, great. Y'all are awesome. Who's ready to take step 1 tomorrow? I feel like that's a lot. There are a lot of people who are ready to take step 1. Okay. So now we're getting pulmonary exam, demonstrates a prolonged expiratory phase. Okay, awesome. Now we're back to the question. So which of the following likely led to the development of the representation? So as y'all are mentioning, right, this new shortness of breath is really the symptom that I think we're dealing with. And because his cardiac exam is normal, right, or he has a normal S1, normal S2, and no JVD, that tells us that the shortness of breath probably is more related to a pulmonary issue. At least it's not related to heart failure. Okay, so at this point, we could look at the answer choices. For me, I'd like to go back and try to think through, okay, well, what might be going on here? What could be underlying this cause? What's the diagnosis? And so someone had mentioned COPD. A subset of COPD would be chronic bronchitis because of the sputum production. I would also put emphysema on the differential, just because, you generally would think chronic bronchitis with sputum production, but with the 7-year pack-year history of smoking, you could put emphysema on the list too. And then, it doesn't really sound like a restrictive picture, right? It definitely sounds like a obstructive picture because he's having this prolonged expiratory phase. So those are kind of the two things, the two subtypes of COPD that I would have on my differential. And let's see, is there any reason why he might be having worsened COPD symptoms? And I think so. I was looking through the chat. I think somebody probably said this already, but why might he be having worsening COPD symptoms after his MI? And we talked a little, perfect. Oh, great. So he's been put on a beta blocker, which is great for somebody who's post-MI, but why might this particular beta blocker be an issue? Propranolol, right, is a non-specific beta blocker, and so you can get issues with the pulmonary system. Great. Oh, y'all are killing it. Okay, so we did all of this without looking at the answer choices, or at least I like halfway did. It's really hard without putting a sticky note on my screen. But we can then look at the answer choices. And what I like to do is if you have a really good idea of what the answer choice should be, go and try to find it and then check that box, right? So let's look and see, boom, answer choice E, COPD exacerbation, right? So I would say to my student, if you feel confident about it, you can pick it and move on, right? If you know what's going on, if you feel 100% based on the history and physical and all the information they're giving you that this is a COPD exacerbation, don't second guess yourself by looking at the other answer choices. If you are 100% certain, go with that feeling. If we were to think about some of the other answer choices, and I encourage them to do that on review, you can go and look and see, all right, well, what do these other answer choices look like, and why do they not fit? So we can run through these, quickly. So cardiac tamponade, you would pretty much expect there to be a difference in the cardiovascular exam, right? You might have distant heart sounds. You would generally expect there to be JVD, right? Oh, love it. Y'all are killing it. Oh, gosh, you're going to put us out of business. Everybody's doing great. Ventricular arrhythmia, right? Normal S1, S2. So unlikely that his heart is, beating irregularly. Acute decompensated congestive heart failure, right? There's no JVD, so unlikely to be any sort of heart failure. And then stent thrombosis, he's having shortness of breath. He's not having chest pain. I would also expect, again, going back to the JVD, if he's having thrombosis, then he might be experiencing some heart failure as well. And so that could lead to some backup and increase in the pressure within the pulmonary system. And finally, which I think everybody else pointed out, is the prolonged expiratory phase of the pulmonary exam is really, really crucial, right? That's classic for an obstructive pulmonary disease. So y'all did great. So I think we settle on the answer choice E. Mike, any tips, any additional things you would recommend for this question?
No, I love that. I think everything you described was perfect. And I just got to give a shout out to everyone. You guys are really doing well. I'm very impressed. Keep the knowledge coming through the chat box. All right, so we'll wrap up with one last question and kind of give you one more example of how we approach things. And we can be pretty quick with this one now that you guys kind of have the flow of how we approach this. Start with the question itself. What's most likely for the patient responsible for the patient's edema? And I'm still a proponent, honestly, I'm still a proponent of just taking a quick glance at those answer choices. We're dealing with those Starling forces in this case. You have capillary hydrostatic pressure, capillary oncotic pressure, and lymphatic drainage. And then variations on that kind of thing, decreased, increased. And so that's kind of the gist of what we're focusing on is what's going on intravascularly as it relates to fluid. 54-year-old presents with lower extremity swelling. And now it's taking an interesting turn. His urine has an uncharacteristic frothy appearance recently. And so when you hear that, you really should start thinking about proteinuria. That's kind of the test writer's way of communicating to you proteinuria. He has a past medical history of hypertension and type 2 diabetes, but it seems like he isn't on any therapy for that. And so when you're thinking about proteinuria, I think that on some level, both of these things are not, the kidney does not like both of these things, but especially would not like type 2 diabetes in the context of when you start losing protein. Afebrile, he's hypertensive, which we know from his past medical history. He's pulse is normal, respirations are normal. And then he has 3+ pitting edema up to his knees bilaterally, as well as periorbital swelling. And then urinalysis reveals 4+ proteinuria and fatty casts without ketones. Serum glucose is 248. So kind of in the constellation of all that, this patient is presenting with a syndrome. He has a collection of problems, a collection of signs and symptoms. And so if anyone has any thoughts about what that might represent, feel free to drop that in the chat. Complete blood count is normal. And so which of the following, coming back to the question, which of the following for this patient's edema? So great. So people are already chiming in. Diabetic nephropathy, nephrotic syndrome. Perfect. So this is nephrotic syndrome, presumably related to his diabetes. Losing a lot of protein. Think about protein as that substance in your blood that helps hold on to fluid, helps pull fluid into the intravascular space. It's osmotically active. And so, you're constantly having this equilibrium of fluid leaving your arteries and veins, the capillary beds really, and coming back in. And so the blood pressure that you have pushes fluid out, the oncotic pressure, and to some degree, the tissue hydrostatic pressure pushes fluid back in. If you don't have that intravascular protein content, you lose that osmotic gradient. You lose that ability to pull fluid back into the capillary beds. And so, I think I might have been kind of circling around the answer and maybe giving it away. I'll turn it over to you guys and let you chime in what you might think it might be. Great. So everyone is perfect. So that you have a decrease in that capillary oncotic pressure as a result of decreased protein content and then decreased ability to pull fluid back in. Quickly going through the other answer choices, decreased capillary hydrostatic pressure. You'd expect this more in like a hypotensive kind of process. Decreased lymphatic drainage. This would occur in the setting of if for whatever reason you have scarring of lymph nodes. If you had, for example, in the derm world, we often talk about sentinel lymph node biopsies for patients who have melanoma. And so that might be something, if you have that, if you want to get really kind of out there, Wucheria bancrofti, so kind of strange diagnoses that might cause lymphedema, that would be what you're referring to with C. And then you're not having increased capillary hydrostatic pressure. That also would cause edema, but that would happen for a different reason, not for the oncotic pressure, the protein losing information, the protein losing process that's happening in the kidney. And then you're not having increased oncotic pressure for the reasons we discussed, and hydraulic conductance is a little bit of a distractor here. Alec, anything else you want to add for this?
No, I think that was great. People jumped right on it, caught right onto that type 2 diabetes that's been untreated for, however long, and the likelihood of that resulting in nephrotic syndrome. Love it.
All right.
All right. Oh, and I did see one other question about, the first question that we actually didn't go through, which was an ARDS question. So alveolar hyaline membranes, if you were curious about what the correct answer was for the first question. Okay. So that's all that we have today. We're going to do our live Q&A, but real quick before we jump in, if you're interested and want a little bit more information about what we do at MST, feel free to reach out to us. We a lot of what we do is one-on-one tutoring. For the most part, we're medical students, residents, and attendings who really just love to teach and love to work one-on-one with students, and we want to help everybody do as well as they can throughout their coursework, throughout, studying for the boards, studying for licensing exams, studying for the MCAT as pre-med. So, you're obviously beyond the level of a pre-med at this point. But again, it's really, for us, it's about the relationships that we get to build with our students as tutors and mentors. And I keep in touch with a lot of the students that I've tutored. And for me, I've been in medical school for like 8 years now as an MD PhD. So I love hearing about, all of the great things that they're doing as residents. And I personally have had a really, really great experience working with every single person that I've had the pleasure of working with at MST as a tutor, and all of the students that I've been working with as well. So, if you have any questions for us, if there's anything that we can do to help you at any point, please feel free to reach out to us on social media, by email. We're happy to communicate with you and help in any way that we can. And yeah, I think we can head to the Q&A. Yeah, so I've seen a question here. What's the best way to actively study from first aid? And that's kind of a loaded question. My personal feeling is that it's really hard to actively study from first aid. I use it. I generally work with my students to use it as a way to review in combination with reviewing from UWorld. So as you're doing questions, as you're reviewing from UWorld, reviewing that same section, usually the first page or at least one section above and one section below in first aid, is how I try to keep that process as active as possible. Some people can just read first aid and it sticks in their brain. I'm not one of those people. A lot of students that I've worked with are not those people. So trying to tie it in with UWorld review is one of the better ways to do that. The other thing that I've worked with students to do is to, again, use either pre-made flashcard decks or to try to make their own select flashcards for parts of first aid that they find really, really challenging. I'm a huge proponent of using flashcards to help with active learning when you're not doing questions. So that's a really Anki, Quizlet, Memorang, whatever you want to use. They're all really powerful tools to help you be as active as possible. So you can utilize that as a way, not as a resource per se, but really as just a tool to help you access the resources that you've already selected. Yeah, Mike, I don't know if you have any input about first aid.
I agree wholeheartedly. And I'll be honest, I find that first aid is best, kind of like we were talking about before, for filling in the gaps.
Yeah.
I think that as you're working through it, just find things that you didn't know before. Again, kind of in the spirit of always be learning something that you didn't feel comfortable with prior to when you had started reviewing that. And first aid is no exception. All right, let's see here.
Ooh, here's another good one. Random UWorld question sets or Oregon system specific blocks. What are your thoughts on that, Mike?
Yeah, I find that you could go either way. I think that earlier in your study period, it helps you have a little bit more structure if you go by Oregon system, just so that you can kind of package everything into discrete entities, align it with the first aid. It's kind of nice to have a theme for the day. Like today, I'm going to be focusing on cardio questions, cardio first aid. As you're doing subsequent passes and getting closer to your test day, the benefit of doing mixed questions increases because it more closely approximates what your test day experience is going to be like. I always use the example of if you're in an endocrine block and you know that you're dealing with endocrine questions and you get a question about a cardiomyopathy, you're just that much more primed to look in the answer choices for the endocrine answer than to think more broadly about the full differential of things that might be causing that cardiomyopathy, i.e. all of the cardiovascular causes. It's just an advantage going into the question knowing what organ system it's going to come from is an advantage that you're not going to have on test day. And as you get closer to your test, it's best to make your studying, especially as it relates to questions, approximate the testing environment as much as possible. I don't know, Alec, do you have any other thoughts about that or approach it differently?
Yeah, again, I've done different things with different students based on their preparation. So I agree. I don't think that there's a wrong way to do it. I would suggest strongly that the closer you get to your test day, the more mixed blocks you should be doing. But if you want to start with some mixed blocks, because you have gone through all of M1 and M2 to this point, I think it's fine to incorporate mixed blocks from the very beginning if you feel like that would be helpful to you. One thing that I sometimes work on with my students is do what I would call like cumulative blocks. So as you are studying cardio, you do a block of cardio questions, and then you do a block of cardio questions plus everything else that you've studied thus far in your dedicated study period. So if you did pulm and renal before that, then you'd have a block that's cardio and pulm and renal all mixed together. So it helps you kind of prepare your mind to switch between topics, but you're not getting asked questions about stuff that you haven't studied in months that are just going to throw you off completely, and you're going to get sad about not having any idea of what's going on. So that's another kind of strategy that you can use.
Great question here about USMLE Rx, and then maybe we can broaden that to thinking about other Qbanks as well.
Sure.
Alec, do you often recommend other Qbanks besides UWorld? Let's say if students have the time, or do you just focus on more subsequent passes?
Yeah, that's a really great question. I think it depends on a couple of factors, and the main one really is time. So if my students, if they've used a question bank up through a certain point during their M2 year or whatever courses they were doing prior to their dedicated study period, I sometimes will try to incorporate that along with UWorld questions into their dedicated study period. Ultimately, my priority is for all of my students to get through UWorld at least once. If you do that, then beyond that, I'm fine with whatever else they feel comfortable doing. So if you feel like I want to do all of UWorld and then I really want to see some brand new questions that I've never seen before, I'm totally fine with students who want to use USMLE Rx or Kaplan after they've done UWorld, or kind of mix it in while they're doing UWorld. Some students, UWorld is the gold standard. So if you purchase a subscription that allows you to reset the question bank once you finished it, I say, why spend money on another question bank if you can use the gold standard again? And again, like Mike was saying earlier, it's about quantity when it comes to questions. The more questions you do, even if they're the same questions, like the better you're going to be prepared for the exam. So I don't think there's anything wrong with Kaplan or USMLE Rx if you want to use them, but I would strongly recommend doing it all of UWorld at least once.
I love working. I love doing these webinars and hearing it because I just agree 100%. And like everything you said is exactly what I recommend to students. My opinion is UWorld 100% has to be front and center. And then after you finish that first pass through it, a second pass, UWorld is so high quality that a second pass through UWorld to me starts to become comparable in quality to a first pass through another Qbank. And from there, it just becomes stylistic about what, what you like. And if you want to try something different, to me, a lot of them are pretty equivalent. Kaplan, RX, Amboss, you can kind of pick and choose. But also at the same time, perfectly acceptable just to do a second pass through the UWorld. To me, both of those are equally productive uses of time.
And so here's a question. I'm going to broaden this question a little bit. There have been a couple of questions about, memorizing equations, memorizing algorithms, and I'll ask you, Mike. Do you have any recommendations when it comes to some of those concepts that are what I would call kind of pure memorization, where you gotta just drill down and brute force it? Any tips or tricks when it comes to some of those topics?
So I'll be honest, when it comes to the rote memorization and biochemistry, some of the really nitty gritty microbiology, sometimes it's best to triage that a little bit later in your study period because a lot of this stuff actually is really important and does come up in clinical context. And it's worthwhile to know for your future practice. But I'll tell you up front, galactosemia is not really one of those things. And so, that you could probably wait until closer to your actual exam and do a blitz through the biochem to try to hold on to that information. I'm very particular about equations. And I am of the opinion that if you are just memorizing equations in isolation, you're probably wasting your time. It's so much more advantageous to understand what relative risk reduction is than to just, in isolation memorize that because they're not going to be like, well, here are all of the variables in the equation, the exact numbers that you need to plug in, and then just make you plug and chug. They're going to give you this long protracted vignette or an abstract where you need to understand the pieces and figure out how they fit into the overall picture. And so to me, as it relates to biostats, as it relates to a lot of the cardiovascular concepts and pulmonary mechanics, so much more important to make sure you understand what the equation is communicating, and so much easier to remember if you actually know where all of the variables are coming from. Alec, any other thoughts about that?
Yeah, I completely agree. As much as you can try to understand the underlying math, the underlying physiology, the underlying reasoning behind why that equation is used, whether it's, cardio or pulmonology or, biostats, it makes that information stick. So the more that you can try to know what the reasoning behind it is, the better off you'll be. That said, I also agree that if you do want to just try to cram it, I'm totally fine with my students if they're like, I'm not going to spend time trying to learn what this 2x2 table is to get 3 or 4 questions maybe on day of. So I'm just going to wait, and I'm going to just kind of cram the equation right before I walk into the testing center and hope that it sticks long enough that I can get that question right. And so, when I work with my students, we really try to triage down exactly what they're going to memorize and what they're going to actually try to learn. And I really try to limit them in what they feel like they want to cram, because when you are tearing through biochem, cramming seems like the better option, but, taking a little bit extra time to try to learn what's going on and why the pathways are behaving the way that they are, really will help you in the long run, long run career wise, but also for the test. So we try to limit the amount of cramming that we do.
Very true. Well, thanks everybody for joining us tonight. Phenomenal participation. You guys did an incredible job with those questions. You've also brought in great questions tonight. If there's anything that we didn't get to at any point, feel free to send us an email, give us a phone call, check out our website. We have all of our contact information down at the bottom. Again, just a very friendly reminder about the survey. It's literally takes 15, 20 seconds, and it's super helpful for us. But again, just thank you for joining us and listening to our kind of spiel on how to approach all these things, and hope it was helpful.